Hello everyone and welcome back to our inflammatory bowel disease series on YouTube and on our app. And today we are diving into part 4 of this series, focusing on a crucial topic for surgery residents, that is pouchitis, diagnosis and management. So friends, pouchitis is an inflammatory condition that affects patients who have undergone ileal pouch and anastomosis, that's IPA, commonly used to treat ulcerative colitis. As surgery residents, it is essential to understand how to diagnose and manage this condition effectively. So let's get started. We have already uploaded 3 videos in this series, and these were quite lengthy videos on ulcerative colitis, Crohn's disease, and ileocecal Crohn's disease. And it is desired and must that you watch the previous episode, at least the ulcerative colitis video, to have a better understanding of this problem, that is pouchitis. So basically, to keep the video length short, we have divided this topic into 3 videos or maybe 2. I will see if we can condense the remaining part in a second video. And in this part, we will talk about the background and introduction, anatomy of the pouch, different kind of pouches we use, what is the pathogenesis of pouchitis, risk factors and presentation, how to diagnose with the help of pouch endoscopy, and we will also talk about pouch disease activity index. So friends, if you are preparing for your basically super specialty examination or other board examination, pouchitis is one of the most common topic asked about, and you should be knowing everything about this. And to begin with, I'm posing this question for you guys. Just guess the answer, then we will give the answer at the end of this video. So which of the following is the most common complication after ileal pouch anal anastomosis, that is abbreviated as IPAA? For treatment of ulcerative colitis, the options will be pouchitis, small bowel obstruction, anastomotic stricture, abscess and fistula. So let's dive into the topic per se. So friends, basically pouch is created when we remove the whole of the large bowel, that is the colon is removed along the rectum. And there are 2 conditions per se which will require the total removal of the colon, or that will be proctocolectomy, that will be FAP, familial adenomatous polyposis. That is one rare condition and less commonly seen, and more commonly will be ulcerative colitis. So here we remove the total part of the colon, rectum, then we make a reservoir of the ileum, and then we anastomose it with the anus. So that is the ileal pouch anal anastomosis, and whole of the large bowel is gone. As I said, if you are a surgery resident, then you may not deal with many of these cases, but the knowledge about this entity is must. And if you are dealing with the GI cases, or we have a GI surgeons who are, or the colorectal surgeons, then you will encounter these cases. So pouchitis, it is one of the most common complication following restorative proctocolectomy, that we are not giving stoma, we have removed the total colon and rectum, and then we have made a pouch, that we have restored the normal function. And so the normal function of distal ileum is converted artificially into a storage reservoir. As in all of my important talks, I give the reference to the facts and figures, and I encourage my viewers to go through these important articles which we have basically handpicked for you guys. These are the most relevant literature sport to the talk, and you can basically go into these articles and have more understanding. So the incidence of pouchitis is 16 to 48%, and 40% of the patient will have one episode of pouchitis in 10 years, and 70% will have one episode of pouchitis in 20 years. So the incidence of pouchitis 10 years after ileal pouch anal anastomosis will be somewhere around 23 to 60% for IBD and 0 to 11% in FAP. So just remember these facts and figures. So basically we have different kind of pouches, and the most common pouch is J pouch, where we basically fire this stapler between the 2 limbs of this ileum, and these are sewed together. So this is J pouch. Most commonly we also follow this pouch only, and other options are like we have S pouch and W pouch. So for theoretical purpose, just remember, but the best pouch with best function is J pouch only, and our discussion will be basically focusing on this entity only. As I said, the J pouch is the most common pouch used, and here are 2 handles, while in the S pouch we have 3, and W pouch we have 4 handles. So after 1 year of J pouch creation, patient will have around 5 to 6 stools per day and 1 to 2 stools in the night. And as the pouch matures, they will have a better control. And SNW has 3 and 4 handles, and these are less frequently or less commonly used pouches. J pouch is simple to create and easier to basically reconstruct and anastomose, but the volume is less, the capacity is less. It is around 228 cc. For S pouch, it is 320 cc, and the maximum capacity is for W pouch, that is 440 cc. And so in J pouch, we require around 30 to 40 centimeter of the distal ileum. In an S and W pouch, we require around 50 centimeter. So far from the discussion, you must have understood that we create this pouch as a reservoir and anastomose this thing to the anal canal. And if there is inflammation of this reservoir, then this is a pouchitis. So it is an idiopathic disorder. The exact cause and pathogenesis remains to be many known, and there are many meta-analyses comparing FAP versus ulcerative colitis, and it is the highest incidence is in the ulcerative colitis. That is 5.5 versus 30%, and it is a significant difference. So we have a higher chances of pouchitis in UC, ulcerative colitis, and ulcerative colitis combination with primary sclerosing cholangitis. It has the highest risk. Again, viewers, I am repeating that please do watch our video on ulcerative colitis. It is around 1 hour video, and we have discussed everything in detail, and you will have a better perspective of this talk also. So the ulcerative colitis patient will have with the extra intestinal manifestation has a tenfold higher chances of pouchitis after 5 years. That is 48% versus 4.6%. Again, it is significant higher fair chance of developing pouchitis. And so it is assumed or thought that the pouchitis in these patients is mediated by same pro-inflammatory mediators, which is leading to the extra intestinal manifestation. And we have already discussed like the involvement of joint, eye, skin, liver, and there are many others. So these constitute a spectrum of extra intestinal manifestations. And other risk factors can be post-op complication. There is, if there was any leak, or the age is higher, patient is a non-smoker, or there was a post-op use of NSAIDs. So again, if you are dealing with a patient of a basically ulcerative colitis whom you are planning this restorative proctocolectomy, then we should consider that avoiding the basically use of these painkiller NSAIDs. And as such, ethically we cannot tell the patient to smoke, and the rest of the things are not in our hand. So this is the preventive factor that you can keep in mind. There is some literature evidence that this pouchitis is also infective in nature, and there is a basically this is not a natural reservoir. We create this reservoir, so there is a bacterial stasis and overgrowth, so that leads to the morphological changes like there is a like fecalization of the intestinal content when in a chronic obstruction, so somewhat like similar picture. And histological study shows there is a chronic metaplasia, inflammation scores high in pouchitis. The use of antibiotics help to control the pouchitis, so that is a indirect evidence to suggest that the inflammation because of the infection is and can be one contributing factor. So again, if we analyze the this flora of these pouch contents, so there is a high concentration of anaerobes and aerobes, and that leads to the architectural changes. That is basically reparative response to the inflammation because of the bacterial stasis. Just remember these other risk factors which can be basis of many questions in the basically super specialty examination, like genetic polymorphism, interleukin 1 receptor antagonists, NOD2 card 1536 genetic status, of if there is a non-carrier status of a tissue necrosis factor alpha allele 2, or if patient had preoperatively extensive ulcerative colitis, there was a evidence of backwash ileitis, or there was a proctocolectomy thrombocytis, or concurrent primary sclerosing cholangitis. So this is a repetition of my previous things which I have already said, that is seropositive P ANCA, non-smoker, and NSAIDs. These are all risk factors. And just remember that backwash ileitis, like we are using the terminal part of the ileum as a reservoir. So backwash ileitis, which we have already discussed in the ulcerative colitis discussion. So if we are using that disease part in the creation of the pouch, so there are higher chances of the pouchitis. So there are different two entities like acute or chronic pouchitis, and they may have a different risk factors, different profile, which we will discuss as the discussion will evolve in this video or in the subsequent part of this discussion. Other things like preoperative, we had indeterminate colitis, like we were not sure whether we are dealing with ulcerative colitis or Crohn's disease, or there was presence of Crohn's disease related antigen from Pseudomonas fluorescens, or anti-Saccharomyces cerevisiae antibodies, that is ASCA. So these are all risk factors. So if we have a preoperative knowledge of these things, then we can tell the patient, or we can counsel them accordingly. So then patient is psychologically better prepared that he can develop these kind of complication. And just remember, friends, this is a very difficult situation to handle. So we will discuss more. So these patients usually present with symptoms resembling ulcerative colitis. So like a patient will report to you that, look doctor, I'm having the similar complaints which were there before this extensive surgery, in which all of my colon and rectum was removed, like there is increased frequency of bowel movements, there can be incontinence, there is urgency, cramps, or bloody diarrhea, which are all classical symptoms of the ulcerative colitis. And if these symptoms persist or reoccur after IPAA surgery, then they should raise the suspicion of pouchitis. So as I said, there is an increased stool frequency, urgency, patient need to rush to the toilet, the tenesmus, the feeling of incomplete evacuation or incontinence, nocturnal seepage, abdominal cramping, pelvic discomfort. The classical bloody bowel movements which are typical in the ulcerative colitis are not common, are not seen, and severe pouchitis can lead to the fever, dehydration and malnutrition. The differential diagnosis of this condition will be cuphitis, that there is a small cuff of the rectal mucosa remaining behind and along the anal canal. If you have not gone deep up to the anal canal, then cuphitis, or the Crohn's disease of the pouch, or there is a proximal small bowel bacterial overgrowth, or irritable bowel syndrome. So these are all differential diagnoses, and we will discuss about these entity in the later part of this video or in the subsequent parts. So how to diagnose this condition? So the pouchoscopy, that is the endoscopic examination of pouch, is the gold standard for diagnosis, as it allows a direct visualization of the pouch mucosa. You can inspect the ileal mucosa and how much is the inflammation, how much is the extent, kind of inflammation. And the pouchitis is typically defined by endoscopic and histological criteria such as increased vascularity, friability and erosions. One has to understand that the pouchitis is not a basically all or none diagnosis. It is a spectrum of disease, and basically there is no strict diagnostic criteria, and there is can be mild to severe inflammation. So we have to see all the findings at how much is the inflamed friable pouch mucosa, whether they are ulcerative exudates, how much is the inflammatory infiltrate, bilious atrophy and cryptapsis. These are basically all the markers, surrogate markers for your diagnosis. So I have taken these pics from Shenby et al. And I'll apply some kind of filter, otherwise I don't know whether we can use these pics from these journals so to avoid the copyright strike. So viewers can go through this paper. This is a free paper available on PubMed, and so you can have better perspective. So basically pouch endoscopy, it yields valuable information on severity and extent and how much is the backward dilatation in the pouch. So there is a normal afferent limb, so how much is that affected, whether we are dealing with the Crohn's disease of the pouch or cuphitis there, and what are the structure abnormality, like there can be stricture, there can be fistulas. So in this picture, figure A is extensive inflammation, figure B is normal mucosa, and figure C is basically this lower panel A is basically this is a history of Crohn's disease, and the figure lower panel A figure is on the right side. This is cuphitis. So cough, as I said, if we have not gone deep enough and we have left the part of the rectal mucosa and we have anastomosis that rectal mucosa to the ileal pouch, that can lead to cuphitis. And friends, I encourage you to join the channel membership or to download the app to have a premium access and for a better learning experience. The link for everything is available in the description and pinned comment section of this video. Do like the video and subscribe to our channel if you're watching this video on YouTube, and hit that bell icon for all the future updates. Endoscopically, it is better that we understand the this phenotype of J pouch. So when we are seeing from below, so as I said, we have basically made a J and applied a stapler to create a common lumen. Then it's sewn together. So there will be afferent limb, as you can see on the right side of screen. So there is a tip and there is a common cavity. So there is an inlet afferent limb. Then there is a rectal cuff. If we are left, normally there should not be any rectal cuff left behind. That can lead to cuffitis. And with this is so there's an afferent limb inlet, there's a tip which will be the blind end of the J, smaller limb of the J, proximal distal pouch, rectal cuff, anal canal, and perianal area. So if there is afferent limb inflammation, stricture or perineal fistulas, so if the inflammation more on the afferent limb, the limb which is basically bringing the effluent to the pouch, then this is a suggestive of Crohn's disease. So if the involvement of the rectal mucosa, where we have sewn it to the basically with the help of stapler to the anal canal, and there is a rectal mucosa, that is a chance of cuffitis. You can take the biopsy from here and understand if we are dealing with the Crohn's disease of the this pouch, then this is a high risk for pouch removal. And so accordingly all these things will be able to guide the treatment, and we can switch over to biologicals or the steroids, whatever is required, because in some of these patients may require the cuff excision or the pouch excision. Like in any inflammatory condition of IBD like ulcerative colitis or CD or other things, we have different scoring system. We have this scoring system for pouch disease activity index also, and it is based upon different criteria like clinical, endoscopic, and histological parameters. So it is basically objective criteria to define the severity, so it will avoid any basically the difference between the two clinician. So histological, endoscopic scoring system, clinical, and Pouchitis is defined if we have a total score of more than 7, and later on this score was modified and the histological score was omitted. So we have modified pouch disease activity index score also, and it has a similar accuracy. If you check the literature, then Sir Shenby, I mean, he is one of the most prominent name when you are talking about this Pouchitis. So I encourage the viewers to go through some of these articles, important background articles by Sir Shenby, and link is given here and in all the relevant talks. So this is the basically these are different criteria like stool frequency, bleeding, urgency, fever, endoscopic inflammation, histological inflammation. So we give different points like 1 to 3, 0, 1 to 3, and if we have a total score of more than 7, then we can reach the diagnosis of acute pouchitis. That we have reached the end of this video, and the rest of the discussion will carry forward in the next video. So I have asked this question: so which of the following is the most common complication after the ileal pouch anal anastomosis, that is IPA, for treatment of ulcerative colitis, that is pouchitis, small bowel obstruction, anastomotic stricture, abscess, and fistula. So I think now you can answer this better. So answer is A, that is pouchitis is the most common complication after IPA. And as I said, up to 70% of patients after 20 years post-surgery will experience at least one episode. The other complications are less common and occur at the following rates, which is small bowel obstruction 42% by 20 years. Just remember, this is again a very significant number. Stricture in 39% by 20 years, abscess in 16%, and fistula in 14% by 20 years after surgery. So in the part 2, we will talk about the treatment of acute pouchitis, what is relapsing pouchitis, antibiotic dependent pouchitis, chronic pouchitis, and a relevant literature view. And if we can condense, then we'll talk about the common mistakes during diagnosis and treatment of pouchitis. This is another question for my viewers, the answer for which I will give in the second part of this video. So you have a 30-year-old man with a history of ulcerative colitis, and patient had a stapled ileal pouch anal anastomosis, and is seen in clinic for follow-up. Over the last 10 days, he developed increasing rectal urgency, tenesmus, diarrhea. 4 months ago, he had similar symptoms and was diagnosed with acute pouchitis. He was treated with ciprofloxacin and his symptoms resolved with treatment. So which of the following is the most appropriate therapy at this time? So now patient is again symptomatic. So how should we treat this patient? So metronidazole 500 mg BD, ciprofloxacin 500 mg BD, BSL, that is a kind of probiotic prebiotic combination, mesalamine enemas, or prednisolone. So just think, or you can comment on the answer in the these comment section on YouTube, or in the you can share the answer in the chat option on the app also. A response, and then we will give the answer in the second part of this video. Thank you very much, friends, for watching this video. Stay tuned for the next episode, and don't forget to hit the like, subscribe, and that bell icon if you have not done it already. And for a better learning experience, we encourage you to download the app, which is available for Android and iOS, or join the channel membership, and the link for everything is in the description and pinned comments. So thank you very much. Stay tuned. Happy learning.